Still, this is the history is still very ancient. When you look at this, yes, they used to believe that ulcers were kept open because they drained evil humors. True. Even good in 1500, an Italian physician, he found that there is no artery without its occupying vein, which is true these days. And Leonardo da Vinci, and now that the circulatory system was like a tree, which many times we see that in our logos. So we have a very solid background and history. Going further, I'm not able to move my slide. I just stop sharing for a minute and go back again. I'm not able to proceed because oh, come on. What a glitch. Is it because I selected that?
So what's happening?
I'm not able to move on the slide.
So in that case, you can go one by one slide also.
Yeah, I'll do that now. Is the screen visible?
Yes.
Yes. Yeah, okay. So I think I'll have to do with this. So again, we go back to history in year 1500 to 1600, that century. Italian anatomist.
In that case, you can go one by one slide also.
I'll do that now. I think, is this okay?
Yes.
Okay.
Yeah. Okay.
So way back, they discovered about the go back history in year 1500 to 1600, that century. Italian anatomist.
In that case, you can go one by one slide also.
I'll do that now. I think, is this okay?
Yes, this is okay.
Okay. So way back, they discovered about the go back history in year 1500 to 1600. That's yeah. So they could demonstrate valves in the vein, which is very pertinent in today's world. They are very important for the redirectional flow of the blood. So, and even the doctors were worried curing leg ulcers. They thought that if you do so, the bad blood would reflux and it would lead to suffocation and madness. So look at the concept people had those days in mind. And this is the age when probably modern science evolved. William Harvey as all of you know, was the first one to discover blood circulation. And he also proved that the valves allow blood only to flow in one direction. So very interesting history. Even way back in 1700 to 1800 in England, the ulcers were very probably the reasons were not very clear those days. And for that treatment of the same, the hospitalization was in terms of weeks. Strangely, people believe that in pregnant women, varicose veins were thought to be due to milk in the legs. So very interesting and funny beliefs when we go to the history, we read about it. Finally, it was accepted in the late 18th century that the ulcers were caused by varicose veins. And because of the availability of anesthesia and antisepsis, the doctors were willing to operate them rather than shying away from it. And this 1841, Frederick Tredelenburg was the first one to do ligation of saphenous vein in upper thigh. The surgery is still being practiced today with little bit of modifications, but look at this, way back in 1841, the concept is the same. And those days, unfortunately, patients were typically hospitalized for nearly 5 weeks. This is the time when a modern surgery came in practice after 1900. The concept of flush ligation came, which currently we practice. People used to strip the vein, ligation of perforators, again, somewhere in 1953 by Cockett and Dodd. Again, subfacial ligations by laparoscope called SAPS, extrafacial ligations, sclerotherapy, the venography or phlebography, and knowledge of venous physiology and pathology actually made a lot of difference in the understanding and the treatment of varicose veins. I guess after 2000 and beyond, the ultra-modern varicose vein interventions came into practice. As I said, laparoscopic procedure called SEPS, I think is lasted only for a couple of years. It's very not being practiced truly because of a lot of complexities involved. Endovenous ablation was first done by Robert Mean in 2001, and ever since it has picked up. And today, virtually all varicose veins are being treated by endovenous ablations using different modalities. So all those operative procedures have been, are not being practiced in most of the centers. The new development and technology is also there for valvuloplasties, vein transfers, and valve repair, which was thought of, kind of an impossible because the valves are so tiny. Let's say they are 2 to 3, 4 millimeters, and when you repair them, chances of thrombosis, failure were pretty high. So this was being discouraged. The success was not that pretty high. People were shying away from it, but I think few centers in the world today are working on the valve transfers, and even they're developing synthetic valves to place into the veins. Balloon angioplasty and venous stenting again was not very common, unlike coronary or peripheral artery angioplasties. But this is also being practiced very routinely in centers like ours, if need be. And so this was the history was very interesting. Now look at the anatomy. Further, what is varicose vein? Varicose vein is very simple. Everyone knows these days. Even people know about it. When they come to our office, they say that I have varicose veins. This slide is very important. This slide actually shows where the vein comes from. This if it is from the uh, dermal layer, we call telangiectasia as a spider vein. If it is within a subdermal layer, we call reticular veins. If it is a subcutaneous tissue, they could be perforating vein. In the fascia, it is either great or short saphenous vein. So this is how this is very important to understand for the surgeons, for the doctors who treat varicose veins, that where does it come from. This is the area we call great saphenous vein, where most of the this is the most common variety of varicose veins we see. The vein starts somewhere around in the foot on the middle aspect and goes up right up to the groin in the fossa ovalis. This is very basic about saphenous vein anatomy. This is on the back of the thigh, and the popliteal fossa is small saphenous vein, which is usually along with the sural nerve. And the sapheno-popliteal junctions, there are a lot of anatomical variations, unlike sapheno-femoral junction, which is very important for a doctor to understand, those who treat about varicose veins. And third set of veins are called perforating veins. They are the connecting veins between the deep and a superficial system. And they are very important for the unidirectional flow of the venous system. So these three things are very important for anatomically to understand what kind of varicose veins we are treating. Once having known that, what are the types of varicose veins? Not that all veins are same. When you look at this picture, as I said earlier, the veins which are seen only in the dermis are called spider veins or telangiectasias. They're very superficial. They're less than a millimeter in diameter. They're kind of a cosmetic spots, having purple, red, or bluish kind of a discoloration. A second variety is reticular veins, which is very well seen in these pictures. They're a little deep in the skin layers, in the dermis, a little bigger than reticular vein, the spider veins, 1 to 3 millimeter in diameter, and they discolor overlying skin, kind of, as you see in this picture. Third would be saphenous varicose veins, which we see very commonly. All of you must have seen these kind of veins. They arise, or they're in connection with either longer, greater, or shorter saphenous systems. They're usually more than 4 millimeter in diameter, because normal diameter of the saphenous vein is around 3 to 4 millimeter. So when they go more than 4, we call more than 6 millimeter diameter is pathological if they have a reflux. They're usually in the subcutaneous tissue, and the overlying skin is normal, unlike reticular veins. So this is what normally you see. This variety of vein, which is very, very atypical or uncommon, and we call non-saphenous or a pelvic veins. These are the veins we see around the vulva, perineum, lateral aspect of thigh, posterior aspect of thigh. What I mean is not in the course of great or short saphenous vein. If you see veins in the other the area in the other in the course of great and short saphenous vein. These are the pelvic veins or non-saphenous vein. In these cases, this SFJ, SPJ would be normal, and the source of reflux in such patients is somewhere high up from the pelvis and usually from the ovarian veins. This area is not well understood by many doctors. One more variety of unusual or rare varicose vein is associated with some kind of AVM, which was described by Himovici way back, which usually we call Klippel-Trenaunay syndrome. There are many syndromes associated with that, where the veins, when the valves are normal, you see a lot of varicose veins, but they're not primarily, they're usually secondary to some arteriovenous malformations. Usually in the lateral aspect of thigh, they're very huge, unlike normal varicose veins, and they could be some limb discrepancy. So when we see varicose vein, we have to make sure that what kind of varicose veins we are seeing and how do they present to us. They present in by various means. One very common is this unsightliness. They do not look good, ugly looking veins associated with skin changes, and people do not like to see that. It is observed, this kind of vein strangely is observed more in man than in women. We believe that it is more commonly seen in women, which is true. The spider and reticular veins are more commonly seen in women. But saphenous vein, even in our own experience, we have seen that we have seen more number of male patients and females, especially saphenous veins. There is no tangential relationship between the severity of varicose vein and pain. You might see a couple of patients who have these veins for many years, 2 decades, 3 decades, and they're asymptomatic. Or they could be just dull aching pain end of the day, which is a concern anxiety for many patients. If this vein if this veins progresses further, there could be psychosocial repercussions. Look at this ulcer. Very difficult to live with ulcer. These ulcers are very difficult to treat, difficult to heal. And that's why people get nervous, anxious, and depression. As this picture shows, these veins also, especially this season in winter, when they scratch that because of dry skin, they bleed, and they bleed so much. They think bleeding is so much, they get scared and come. In fact, the bleeding is not really so much, but everybody gets worried. If you still ignore further, I think they many of them land up with venous ulcer, varicose ulcer, which is, again, as I said, if you don't treat correctly, it is a health nuisance, difficult to get rid of. It's a social disaster, and it takes pretty long time in terms of months to heal. And in 20% of them probably doesn't heal even after 2 years. So it is important for us to prevent this kind of complication like LDS, lipodermosclerosis or venous eczema. Not all these problems are not serious. They are not life-threatening or limb-threatening, but they're very unpleasant to live with. They create social disharmony. Because of this LDS, there could be recurrent infections and economic burden to the hospital and the family both. If these veins, many times I've seen these veins were there for ages, but due to some problem in their immunity, they develop infections, and then it's very difficult to get rid of that easily. So varicose veins, other than just seeing clinically, they could present with different kind of symptoms. Now, why they develop it? As I said earlier, primary varicose veins, they're usually because of the valve failure or a pump failure. The calf pump is people call a second heart or a peripheral heart, where, when it contracts, it pushes blood up towards the heart. When it relaxes, it draws blood from the veins in the calf. So it is very important to maintain the cycle so that the cardiac cycle is maintained. And second is valves, which always we talk about it. Very, very important to maintain unidirectional flow from feet towards the heart. And two paramount veins like great and short saphenous vein have a terminal and a pre-terminal valves at the junction, and which controls the flow of direction from feet towards the heart. And if there is some problem with valve functions, they usually come to us with kind of varicose veins. This is a very common myth in the society that varicose veins occur due to standing posture, which is not true. They do not occur because of standing posture. Probably standing posture might precipitate early, they may present early to us. But the main cause of development of varicose vein is genetic, it's familial. Most of the people, they have genetic predisposition to develop varicose veins. Because of that, there is a valve failure and a valve weakness. When the valve fails, The blood, as I said, doesn't remain in any direction. It comes back, and like a balloon, vein keeps dilating, and they become elongated, tortuous, and they turn varicose vein. Similarly, when the wall is weak, again it cannot sustain the hydrostatic pressure, and the vein gets dilated. When they get dilated, the valves become malfunction. They're not close properly, and the vein gets dilated subsequently. Some nearly 20% of times, these veins also occur secondary to deep vein thrombosis and AV malformations. So it is very important again for a clinician to identify the type of varicose veins, because the outcome matters. When you treat primary varicose veins, the results are very satisfactory, long-term and durable. When you treat secondary varicose veins, the recurrence is very common, unlike primary varicose veins. Not that all of them develop varicose veins. There are some predisposing factors like hereditary, gender, as I said, more common in women, especially spider and reticular veins. White race, posture does contribute, hormonal influences, pregnancy, obesity, pelvic tumors. All these are the factors which probably are important for secondary varicose veins. As I keep talking about, it's a family, it happens in the family. Again, the data is not very strongly supported. But having said that, if both parents have varicose veins, 90% of children might get varicose veins. So it does familial. If one parent is affected, 25% for men and maybe 60% for women will be involvement. And we do see in our practice, when you ask the history, many family members would have the same, especially mother and daughter and aunt. How do we diagnose it? It's a self-diagnosis. People come to our office saying that man varicose vein hai. So that kind of awareness exists in the society. Now, but this is not enough, as because we've been discussing so much. We know that if the anatomical aspect, the physiological aspect, the clinical types, it's important to get some more detail. And ever since the Doppler became available, the diagnosis has become very, very accurate. I remember my earlier days of surgical registrar residency. Those days Doppler was not freely available, very, very primitive stage. We used to do those clinical tests of Tettlenburg, Perthes, etc., and Homans, Moses. All those tests were done. But these days we hardly ever do any test, because what all information you need, single Doppler ultrasound will provide you all the information, like what is the status of valves at the SFJ and SPJ, the flow direction in SSV, great and short saphenous system, the status of perforators, any history of deep veins or deep vein reflux, and anatomical variations. So whenever you see a varicose vein patient, and when you ask for ultrasound, you must write this, that you want this much information from a radiologist or from a vascular surgeon, so that based on this information, you can decide that what exact problem patient has and how can you treat them. So when you get Doppler, you see these two kind of refluxes. Reversal of flow across the great saphenous system in 4 out of 6, very common. Short saphenous is less common, 1 out of 6. And non-truncal, as I said, perforators, ovarian, pudendal, etc., or Giacomin vein. So if you have this information, then only you can offer correct treatment. Otherwise, the treatment fail. And that was the reason earlier we did not had correct information. And that is why the couldn't offer correct treatment, and recurrence was very common, and surgeons used to shy away from the treatment of varicose veins. At times, when you are not sure about, or you do not get complete information on the Doppler study and a clinical examination, you might ask for examination called CT venography or MR venography, which is purely non-invasive studies. We normally ask for this venography when you suspect something in the iliac vein or IVC, because they are responsible for 20% of times for secondary varicose veins. Not very commonly being done though. Luckily, it is very well done in our host city. So that's very good for us. When we diagnose varicose vein, this is how we write SEP classification. What is the clinical classification? C1 means just visible vein, to pain, swelling, edema, ulcer, healed ulcer, no active ulcers. Based on this criteria, we want to write C1 to C6. Again, very important to know is primary or secondary varicose veins. The source, anatomical, great or short saphenous vein, or perforators, reflux or obstruction, or both. So when you see a note from a vascular surgeon, he would be writing SEP classification. This offers a complete diagnosis about varicose veins. Having seen it, as I said, there are many people who live with varicose veins with decades being asymptomatic. Then why treat it? It is not a serious problem. It is not a life or limb threatening problem, but it is a health nuisance, when especially when it gets into lipodermal sclerosis or into venous ulcers. And then, so that's why, to have a good quality of life, probably we should treat them if they're symptomatic. And you look at the risk versus benefit versus cost ratio of the treatment you're offering. Based on this, we can take a decision. But normally, we treat varicose veins when the patients present to us with one of these, when they have pain, calf pain, foot or ankle swelling or leg swelling, dermatitis, lipodermal sclerosis, venous ulcers, infections, bleeding. And some people don't like that cosmetic appearance. So these are the reasons when they come to us, we normally treat with one of those means. Now look at these slides. People have tried so many different types of therapies. Varicose veins have been cauterized, twisted, poked, was ligated, divided, injected, everything possible they have done. Despite this, we do not have a very unique solution. That means we still do not know the right treatment. And recently, we have been treating them with endovenous means, wherein we use different technologies called laser, radio frequency, steam, water steam, foam, glue, etc. So a few points to ponder. Varicose veins treatment to be successful, it has to be very specific regarding the source, precise, appropriate, hospitality concerned, and individualized. Not that one solution for all the patients. It has become certainly better with the understanding of anatomy and physiology, especially through Dopplers and IVUS. We also do intravascular ultrasound, which we have a machine in our hospital. Luckily, only half of the patients will be badly symptomatic. There is no correlation between severity of symptoms and looking at the veins. And the aim of treatment is to remove that reflux across the valve and to improve circulation in the foot. How do we achieve that? We have a couple of options to achieve. One, of course, is a conservative therapy. Second would be drug therapy, surgery, and these days, different endovenous ablations, mechanical. I'll take a few words. You also see these kind of slides on the newspaper about sprays and oils. I don't think they ever work. They're very expensive. Having so many options, how do we decide that which is better for the patient? So to keep these criteria into mind, it is safe, it is effective, it is accepted by the patients and doctors, it is cost effective. Based on these criteria, we tailor, we choose the modality of treatment. This kind of reticular veins normally do not need any treatment, except unless they're very young girls looking for very cosmetically concerned. If they are so, we offer them kind of a CLEX cryolaser therapy. Otherwise, we reassure and do any treatment. Role of calcium dorbicillate and flavonoids, stockings, and skin care, certainly when there is no reflux. Let us say when you get a Doppler done, Doppler says the saphenofemoral junctions, saphenopurple junctions, great and short saphenous veins are normal, and you see varicose veins. These kind of varicose veins usually do not need any intervention or an operation. They can be well treated with dorbicillates or flavonoids, stockings, skin care, etc. When they're symptomatic, then we have surgical options. You see that as we have been doing since many years, ligation of those refluxing valves. And to prevent recurrence, people have tried putting patch also or fascia in between, then clipping the vein, ligating the perforators, and doing a small hoop phlebectomies and remove those whatever veins are seen. And this is which is latest in the practice. We hardly ever do operations now, open operations. Most of our practice, I would say 99% is endovenous ablations, and we have all this technology in our hospital. We use lasers, radio frequency, foam, glue, and all the machines. So that this is all this technology. When you see, this is a radio frequency machine, this is a MOCA, and this is laser machine. I'll show you animation video of a minute or so if time permits. I'm looking at the time. So this is how it is. What happens? Yes. So this is how, like a vein is cannulated with ultrasound at the last point of reflux, like an angiogram. We take 18 gauge needle and inject a small guide wire. Then over the wire, we put a short sheath. Through that sheath, you can see this in the screen. Through the sheath, you can see the laser fiber or RF fiber is inserted, and then the energy is delivered. And one second. So this is how I think. So you see this animation, this is all you need. You need a Doppler ultrasound machine for that. We usually make patients stand so that the veins become visible, and you see confirm with the Doppler sonography in the operating room, and mark them with this indelible pen or ink, so that when they lie down, otherwise when they lie down, all these veins will disappear on the operating table. So it's a surgeon's responsibility to mark all those veins with the pen, so that when again, but you also have a Doppler help. So once you on a Doppler, the last point of reflux, you take a small puncture. All this can be done under local anesthesia or a femoral nerve block. We hardly ever give general anesthesia, or very rarely a spinal anesthesia. So with that, you pass a small needle. You see on the screen that the the wire comes, right. This is saphenofemoral junction. Over the wire, you push this. This is a direct laser sheath and a fiber. Once you go close to the siphonofemoral junctions, make sure you are little 2 centimeters away from the junction. This is the only precaution one has to take while doing the procedure, so as to prevent deep vein thrombosis. By chance, if you fire the vein into deep, and that it causes kind of a DVT. So, oops. Am I audible? Is it okay, Satish bhai? Hello.
Yes, yes, audible.
Yes, you are
Yeah,
audible.
because
Yeah, you are
my my screen shows the internet is unstable. So this is how you inject the fluid around the vein you have been treating, to prevent kind of a thermal damage to the perivenous tissue. And you see the whole vein, the entire area is treated without a major scar, without a major incision, and it's purely a percutaneous procedure under local anesthesia. It can be done as a daycare office procedure. So this is how once you start from the groin, you keep pulling the fiber by centimeter and ablate the entire vein right from the groin up to the point of entry. So this is how the vein laser is being done. Similarly, when you do RFA, it is same RFA also, wherein we put similarly, instead of laser fiber, we put a small RFA fiber and treat the entire vein. So technology is different, but the purpose is same. The purpose is to hit the vein, to create control damage to the elastic lamina of the vein, the collagen of the vein, so that vein initially becomes thrombotic, fibrotic, and then it doesn't remain like a tube. So make a puncture through a vein, pass a laser fiber as animation shows, and start ablating. The third thing, which is very new in the practice, is a glue people use, which you must be seeing in the lot of social media ad being used by many other specialists. The glue is nothing but that kind of a Fabiquick. It is cyanoacrylate, and it is only medical grade, well developed and devised for a specific purpose. Again, you put glue right into the vein gets stuck initially, so there'll be thrombosis and subsequently fibrosis. The whole technology, everything is same. Just look at all under, you see this glue being delivered through a catheter, and you compress vein with the ultrasound probe. So the vein gets kind of a stuck, like truly nothing but a Fabiquick. Unfortunately, we can't use Fabiquick. The glue is pretty expensive. This 2 ml vial costs nearly 70,000 rupees. Therapy we normally, sorry, sclerotherapy we normally use as an adjuvant. Again, we take a drug called sodium tetradental sulfate or escarole, ethoxysclerol, and mix with the air. Like I'll show you in this slide. You take a 2 ml, 0.5, 1 ml of drug, 4 ml of air. With three-way lock, you do back and forth mechanism called Tessai's method. You create a form, whatever veins are visible, you can put a butterfly needle into it and inject that foam. The foam goes all around. If you cannot see the vein, at times you also take help of ultrasound probe you use ultrasound, guide, mark those veins and inject this drug. So any varicose vein surgery, typically we will have three components in our practice. The major truncal veins are being treated with endovenous ablation. It could be laser, RF or glue. The small veins uh, around 5 millimeter and above, we put small puncture called hook phlebectomy or stab avulsions. Less than 5 millimeter, we normally inject something like glue therapy, the foam therapy. So every vein will have three procedures. There are not really many complications. Like if you are not careful, you might see once in a while deep vein thrombosis or other things like paralysis, indurations, bruising, edema, phlebitis, hematoma, etc. are the consequences of a surgery or a procedures, which are very much self-limiting and they disappear with time. Uh, as I keep telling, there are a lot of advantages of endovenous ablation. They're very simple to do. Any doctor can do it. You don't have to be really surgeon to do this. The matter of fact, we run training courses for all the doctors. So it is simple, safe, and effective. It's a daycare and office procedures. Person can go back to work next day. Excellent cosmetic result because there are no long scars. The recurrence is remarkably low, and we haven't seen major complications. Another quick, I think I have 5 minutes. Do you have 5 minutes, Satish bhai?
10 minutes actually. In fact, it's only 8:40, so you can talk for 10-15 minutes more. No problem.
So I was rushing actually. I thought
No. Please go at your pace. We have 10-15 more minutes.
10 minutes. So now this is a set of veins, atypical veins. I remember we were not being taught. We are not aware about it, how to approach them. And as I said, when you see veins in atypical locations, suspect pelvic reflux, ask for transvaginal or a pelvic ultrasound. And on that ultrasound, we have very good doctors in the city who will demonstrate to you that there is a reflux in the ovarian vein. The vein is dilated. There are a lot of veins in the broad ligament. All this, you get a primary information on ultrasound, and which you can confirm with either MR or CT venogram, and they will also show dilated ovarian vein, which is normally not seen. So having this information, the diagnosis is confirmed either by ultrasound or by CT or veno or MR veno, or many times we intend to treat, I do venogram, and if there's a leakage, I treat them. For instance, this lady, recurrent varicose veins because she had previous treatment, and look at the veins and the buttocks.
Oh, sir.
Posterior aspect of thigh. So this is not a typical location for great or short saphenous vein. So you have to suspect that it is something unusual. So reflux must be from the top. We got this thing done, CT, MR, veno. You see this, the whole vein is refluxing. Lot of collaterals are seen. And when you do venogram, you see on the screen that on the screen that it is the dilated ovarian vein, which is not normally seen. And when you see a live, probably it goes right from ovarian vein to opposite side. And so this is how it is diagnosed. And how do we treat them? Again, very simple to treat. Like in angiographic means, we have to make a venous puncture, the transfemoral vein or jugular vein. We go into renal vein, through renal vein, go into ovarian vein. It is very not technically very difficult or challenging. Can be done very safely, easily. Once you are into the vein, we inject and see the leakage, well, like you see in this picture. You see, normally when you inject, the blood has to go up from below upwards. In this case, when you see the catheter tip is into the ovarian vein, and we're injecting, normally blood will go up. Here the blood is going from the ovarian vein to pelvic vein, broad ligament, varicose veins, and to the opposite side. So that means this all area is refluxing. So we have to treat this. To treat this, we use a couple of things. We can put coils here so that the whole vein is occluded. There is no reflux coming from the renal vein and top. Or we can put some foam sclerotherapy or a glue therapy or a plug. So a couple of things we can do. And probably this is how the ovarian vein or a gonadal vein is being treated. You can see now this picture when you see the coil on the top, and when you inject, the reflux is not seen. So this is the treatment for ovarian vein reflux. A word about venous ulcers. When you must be seeing a lot of such ulcers. So when you see this ulcer and you find reflux, venous reflux in the short or great saphenous system, we have to fix with endovenous laser means. If it is not that, there could be post-thrombotic leak syndrome, like sequelae of deep vein thrombosis. I think some other day we'll talk about DVT also. So it's a sequelae of deep vein thrombosis not being treated correctly in time. They come with these ulcers, and these ulcers, they respond very well to therapy called 4-layer bandage system, wherein this, when you see on the screen, all 4 different kind of bandages are available, like soft roll, less stretch, strong stretch, and a Coban kind of a bandage. When you apply this bandage right from toe up to the just below the knee, and keep it for a week and keep changing every week or 5 days, most of the ulcers would heal in few months. So this is again a very good therapy for venous ulcers. What about recurrent varicose veins? I remember when I was surgeon, we used to shy away from this operation, saying that all the patients will come back with recurrence. So it is better not to operate those patients, which was true those days because we had a very poor understanding of the anatomy and physiology, especially physiology. With the help of Doppler, now the diagnosis is very precise, and now we know what we are treating. Despite that, recurrence is, I would say, is guaranteed. Recurrence after surgery is usually 30% at 5 years, but even after endovenous ablation, it is 20% at 10 years. So I tell all my patients that it will come back, might come back in 20% of times. Even if it comes back, the severity is not going to be so bad, and we can treat with the different means like only injection therapy called foam sclerotherapy or minor avulsions or ablations. So, and at times we have to identify it's a recurrence or a residual veins. So when the recurrence, people say, when you do not ligate them correctly or do not burn correctly from the close to the SFJ, and all those 3 tributaries are left behind, they may be the source for reflux and recurrence. Or this also be very commonly called neorevascularization. Even you do complete job or perfect job, when they come back with recurrence, and we see a lot of small veins in the groin region called neorevascularizations, and this is something which is not possible to avoid in medical science today. So recurrence again is a reality, but not difficult to treat. So I think this kind of was an overview or A to Z, and as for many years, varicose veins and venous ulcers was considered Cinderella of vascular practice, because they were ill treated. Unlike arterial, the glamour is in the arterial system, but the ease is in the venous system. With the advent of modern and ultra modern management, I think time has come that Cinderella came to the ball. And look at this, the fact here, the way back in 1800th century, this Sir Benjamin Brodie was a physician to a royal family, and he was paid 10,000 pounds a year those days. And he said, gentlemen, there is more than just blue blood in the vein. It was pounds. And in looking at our practice, even the venous disease is more common than arterial diseases. Thank you very much for your time and patient hearing. I think I'll be happy to part of discussion and answer the questions.
Thank you, Dr. Vijay. Excellent presentation, which very simplified. Those videos also were very impressive. We as non-surgeon people also could understand how you are doing the procedure. So thank you so much for that excellent presentation. You can stop the screen sharing and we can have discussion. We can have comments from the audience, questions from the audience.
Sure. Jagdish Bhai Sahib is a senior surgeon. He might have comment to add or some,
How often you do this ligation of long saphenous vein with femoral vein now?
So last 10 years, I don't think I've done one.
Okay. So most of the cases are treated by
Endovenous.
sclerosing therapy.
Yeah, either laser, mainly by laser, sir.
Mainly by laser. Yeah.
I've been doing laser almost for last almost 20 years, I would say. We started in 2003.
So Vijay, what happens to those dead tissue of vein? They get fibrous, you say. Does it make any cosmetic, appearance which is bad?
Yeah, you see, luckily the laser we do to those saphenous trunk, great and set saphenous, and they're in the subcutaneous plane, so they are not visible. So what happens when you, this is another good question you asked, technique for those surgeons who do it. In many of the patients, saphenous vein becomes very superficial from mid-thigh onwards. In such cases, when you do laser, they might get a cord-like feeling for pretty long time. So to avoid that, what we do, when the vein becomes superficial, we normally inject foam sclerotherapy there, which induces less cord-like edema, less induration. And so that you have to decide on table that when you see the vein is superficial, you cannot use laser, glue, or RFA. You have to use foam sclerotherapy there. But even if it is so, it suddenly disappears after a few months.
Okay.
So how you decide in which case you will use laser or radio frequency or glue?
Yeah. Yes, sir. Good question. I have all technologies on myself. We have wherein I have one machine on the laser, other is RFA and glue. I think, sir, my experience with laser is pretty long, almost 2 decades, and I am a laser proponent because I believe even the science also says when these new toys came in the practice, there were a lot of head-to-head trials, sir. Trials of laser versus RFA versus glue, etc. And all those trials have proved that occlusion rate is much better with laser. Pain is also more with laser. But luckily, see, in the West, this practice, when you see an office practice, sir, I visited a few centers where they go home immediately, not even going to the bed. They have purely office center. So there, the story is different. Here, our people anyway have to stay for 24 hours due to insurance purposes. So many of my colleagues, they do on the spinal NC, so pain element is gone. And so I think it's not that really issue. So when you look at the efficacy, I think laser is the best. But having said that, the glue which is recently come in the practice has certain indications. Only select cases glue also can be used.
Glue will act on endothelium. Laser
it's
may
like
act on the middle layer.
That's correct. So laser actually, now the laser again, sir, I have used 3 generations of laser. We started with 810, 980, 1470, now 1940. So 4 generations, the 4th one I'm using now. So all these laser also like less than 1000 is to work on the blood, more than 1000 frequency, they work on the vein wall. And they're more specific, less painful and more occlusive.
So most important question about the cost. I mean, how is it priced, like length of vein, or how do you actually price it?
Normally, now these days we normally in our hospital we typically charge 60,000 for in and out for 24 hours of hospitalization, and which takes care of everything. Doctors, hospitals, pharmacy, laboratory, everything. It's kind of
irrespective of the vein that you do. I mean,
glue is a dismal thing. Glue is not capex kind. So glue cost is different. And that's what we do not promote it much, because glue itself is 70,000-80,000 rupees.
Right.
But still, there are some patients where glue is indicated. But if you look at the ballpark figure, would be 60,000. Unfortunately, also, time is coming. You see this, the insurance company sector is going to control our pricing. They will put a kind of a cap on it that you can charge only this much. And most of the companies would reimburse up to 50 to 60,000 rupees only.
What is the percentage of patients who seek your help for cosmetic versus non-cosmetic treatment of varicose veins?
Plenty. I would say every day I must be seeing. Today, you won't be surprised, though it's subsidized scam, but today we have 8 operations of varicose veins today. But if, I see a lot of patients of reticular and spider veins. I just counsel and assure them that you do not need any treatment. So I would say only 20-30% of patients they need invasive treatment, not all of them. So
in the Western world, more ladies prefer to go for treatment of varicose vein for cosmetic reasons.
I know. I mean, we are not into cosmetic treatment because 2 things. One, for cosmetic treatment, recently new technologies come called cryolaser therapy, wherein we used to take a liquid nitrogen, so that see, all this cosmetic is part of the dermal and subdermal varicose veins. It's part of the skin. So you have to be very careful. All these agents which we use to kill the veins can also cause cutaneous necrosis or a pigmentation. So we have seen early part of practice that in fact they get worse for a few months. So the vein becomes, the skin becomes indurated, pigmented, and they really, patient and you both, really curse that why we did that.
Is
So
there
unless
any
we have
sorry, please go ahead.
Sorry, I couldn't hear you.
No, I was asking a question about, are there any ways to prevent varicose veins?
No way. Certainly not. It's a genetic problem, essentially, hormonal problem, and we cannot prevent it.
Vijay bhai, Hemant Sant here. My question is, this varicose vein problem
Dr. Sant, we
was
can't hear you.
highlighted
Can
in
somebody?
Britain.
Yeah.
Sant, he is not able to hear you, probably because of...
He's muted. No, he's muted. Sant has muted himself.
Now it is okay?
Yeah.
My question is, in Western countries, the ladies wear dress up to the knees, and that is why the cosmetic laser treatment was famous. Now in India, what would you prefer for if the white skin is there and the person gets cosmetic veins, cosmetically bad varicose veins?
Yeah.
What is your preference of treatment?
No, I normally do not treat them. I do not treat them. I reassure, because if somebody wants real treatment, one technology is there which we do not have currently in our armamentarium, is CLACS, cryo laser therapy. Today, if somebody wants, probably they should undergo cryo. Otherwise, we used to do percutaneous, sclerotherapy, liquid or a foam. But I'm not I used to do only for bleeding. Some people come with bleeding from superficial veins. In such cases, I use sclerotherapy, but not for cosmesis. Currently, I do not treat those patients for cosmesis.
For bleeding, I think still simple leg elevation and a crepe bandage and emergency would do.
True.
What is the role of stockings even in today's practice? Made to order stockings.
Those people who have calf pain, especially more at night, end of the day, it has to be customized, or you have to fit into that size criteria. And class 2, the pressure has to be class 2.
Okay. And
between 18 to 24 millimeter of mercury.
So we have methods to do that. I mean, I thought it was very randomly prescribed thing.
No, two things. When you go to buy, the boxes, they should take half circumference at mid-foot, just above the ankle, mid-leg, and just below the knee. Above knee, mid-thigh. These are the criteria. So when you see those boxes, they're well marked. And you have to, looking at those circumference, you have to pick your size.
Okay.
And there are again 3 kinds of pressures, 1, 2, and 3. One is less than 18 millimeter, which is mainly to prevent DVT, called TED stockings. Class 2 is 18 to 24, mainly used for venous pathologies. Class 3 is 24 to 40, which is usually used for lymphedema, for filariasis. Very difficult to wear those. Nowadays, there's a lot of technology. Now wraps are available. Many people are not able to wear this because stocking compliance is very, very poor. So now we have kind of with zipper or with wraps, which is much easy, though little expensive.
how do they act? Wraps, please.
Wraps is same. Basically, wraps is a second layer of it. So they have to stretch to a level. There is a Velcro kind of a fitting, and the second layer goes it. So the wraps are very good for those non-compliant people.
Thank you, Dr. Vijay bhai. You really proved that there is more to veins than just blue. so many details, so much intricacies involved in the care of varicose veins. So thank you so much for enlightening us on varicose veins. It was really A to Z. I mean, I really appreciate the way you covered the whole topic. So thank you so much. And in between, you mentioned that some other day we'll talk about DVT. Surely I'll invite you for another talk. Wonderful. So
I have lots of presentation on DVT, but I'll prepare one for this August gathering, keeping everybody in mind. So that
sure.
Sure, sir.
Thank you
Thank
so
you very
much.
much for the opportunity. Yeah.
Thank you. Thank you all. And we end the session here. Next Saturday, we are not meeting because of the Makar Sankranti Uttarayan. So we'll meet again on 21st January. So thank you all. We